Good morning, everybody. I want to welcome you to the Grand Rounds, in which we have the privilege of hearing from this year's Mumford Awardee. I'm Lisa Dixon, and I am chairing the committee that has made the selection, that makes the selection of the Mumford Award. And I am very privileged to introduce the award and this year's winner. So who is Dr. Mumford? Let's start with that. Dr. Mumford was a sociologist and professor of clinical socio-medical sciences in psychiatry and public health at the College of Physicians and Surgeons at Columbia University, and chief of the Division of Health Utilization and Policy Research, which I would assume is kind of the predecessor of the current Behavioral Health Services and Policy Research Division, which I direct. And she's remarkable. She stressed the human side of medical care and the importance of the social and cultural context. She placed special importance on the relationship between clinician and patient, and on the role of the family in healthcare. She also studied the economic dimensions of health and mental health care, and this lectureship and this award was founded to preserve Emily Mumford's interest in the contribution of the social sciences in medicine. And I think that you will all agree that Dr. Enola Proctor, we couldn't have really a better awardee in honor of Dr. Emily Mumford. I did just a little bit more specifically. She is known, this is Dr. Mumford now, for her work on the effect of psychotherapy in lowering later medical care costs. Studies in which she took part reported that the person who undergoes psychotherapy develops a healthier style of living and is less apt to require unneeded hospitalization, and thus the cost of psychotherapy is offset, the study showed. Her writings included a textbook on medical sociology, interns from students to physicians, and I would love to read that book. And notably, she was born in Missouri. The committee members for the Mumford Award, I just want to acknowledge, include obviously myself, Dr. Mark Ulfson, Dr. Harold Pincus, Dr. Milton Wainberg, and Dr. Anne-Marie Albano. Okay, so Dr. Enola Proctor is this year's awardee, and we are very, very pleased to have her here. Now, I could spend the entire hour detailing her accomplishments, but I know you do not want me to do that, and so I'm going to be brief, because we're going to be able to hear her vision and her perspective shortly. But Dr. Proctor received her bachelor's degree in sociology from Butler University in Indianapolis. She received her master's of science in social administration from the University of Texas in Arlington, and then her PhD from the Washington University in St. Louis, Missouri, in 1978, and she stayed at WashU, from what I could gather, for the rest of her career. And she started again as an assistant professor, and then most recently has been the Shanti K. Khinduka Distinguished Professor of Social Work, and now in retirement. And you know, Dr. Proctor's CV is kind of, it's a little overwhelming to look at, but I just was sort of trying to glean sort of some key elements, and again, sort of more on the process side. What you see is she starts with her own work and her own research and several foci, but one of the things I picked out was a kind of a interest in the issues of race and minority status and really personhood in the context of treatment and education. And then she starts to mentor others, and the scope of her papers begins to expand beyond just her own focus as she's collaborating. And then suddenly you see she's like directing 6 different centers, okay? like, you know, and so you can just sort of see her influence and her kind of intellect kind of expanding in this space. And then I think what then sort of toward the end of the most recent aspects of her career is that she actually, and I think we're going to hear about this, sort of grabs and shapes and forms a whole area of science, of implementation science. And so this is a person who, perhaps more than any other individual in the field, has helped not only to define implementation science, but also to create pathways for young people, for people researching other areas to focus on and conduct high-quality implementation science directed at improving the care of individuals with individuals with mental illness. So I'll stop there, and I'll have Dr. Proctor come on up, and I want to have you, present you with this medal, which you'll have to carry back with you. It's kind of heavy. Here we go.
Oh, it's beautiful.
Yeah. And we'll take the pictures afterwards. But
beautiful.
Okay.
Thank you.
Anyway, we're so glad you're here, and we're really eager to hear from you.
Thank you, Lisa. Thank you very, very much. I am so honored to be the recipient. It's a beautiful piece. I hope you'll get to see it as well. And I want to thank the members of the committee. Have so many friends here. I'm delighted to have an opportunity to see you. And it's wonderful to be here at Columbia and the New York State Psychiatric Institute. You are really pioneers in this field, and the work that you have done, the work that you are doing is just so important and so impactful and inspiring. And I'm also really pleased to be in the home turf of one of my mentees, Dr. Sapana Patel, who was in the first cohort of the Implementation Research Institute, which I'll talk a little bit about. And as Lisa said, my career has been in mental health services research, and of course I've therefore, like everyone in the field, followed your groundbreaking research. Want to get my disclosures out there, where I get a little bit of money. And as Lisa said, I've recently moved to Emerita status, which at Washington University provides 50% employment. I can't tell you how good 4-day weekends are. Someone said, now I'm really working on my PhD in physics, trying to fit 100% into 50%. So if I get that figured out, I'll let you know. But I really was impressed as I learned a little bit about Dr. Emily Mumford, and it reminded me of someone who has had a very strong connection between your department and the Department of Psychiatry at Washington University in St. Louis. She is someone who tremendously influenced my work. You see, I was very fortunate to be mentored by the great Lee Robbins, whose partnership with your Robert Spitzer moved us to operational criteria of psychiatric disorders. When we received our first award for the Center for Mental Health Services Research from NIMH, I was a bit daunted by the challenge of establishing infrastructure, launching a research agenda, mentoring junior faculty, postdocs, and doctoral students. So I picked up the phone and reached out to Lee Robbins, who is so gracious. Did anyone know her? She's passed away now, but what a lovely person, and what a gift it was to me. She agreed to be my go-to person for advice in developing a field, in mentoring others, and we fondly agreed that she would be my center mentor, and we enjoyed that relationship. And she also, her approach to work, I think, greatly influenced mine. This picture comes from the cover of a Washington University feature on her, where they characterized her as a great sociological sleuth. And Lee told me and many others that the joy of research is asking questions. You think about something, you're troubled by something, and you follow the questions. And I'm very grateful for her curiosity, the ties that she had with giants in the field nationally, including notably here. And I have really focused my professional curiosity on the question of how adequate is our nation's mental health care. We've had many efforts to take a look at that. I think the first president who really put it on our agenda was Jimmy Carter. And many of you may have also heard his wife, Rosalind, say that she became passionate about mental health because when he was running for governor, so many people came up to her and said, "Can you help me with this situation?" So Rosalind was a pest to Jimmy, as she says, and she told him she wanted him to take a look at how well we're doing at meeting the needs of people with mental illness. As president, Jimmy Carter said, "How are we doing?" And lo and behold, we didn't have a lot of data. And the grants that followed really helped fuel the field of mental health services research to figure out how well we are doing. Of course, over time, your investigators in mental health services research have pursued a variety of routes to try to improve mental health care. We've worked on access, system coordination, co-location, and then as I pursued questions in each of these routes, I have landed on the very thorny questions surrounding how do we implement care that we know works. So, we know that we have a critical problem with access, that primary care and social services are filled with people who present with undetected, untreated illnesses. We have tried to integrate systems as a way of improving access, and yet we're troubled by data, very recent data, that over 57% of people with need don't get treatment for a variety of reasons. But I think we, as service providers and researchers into the system of care, this is our challenge. It's not their problem to, at the times in their lives when they have overwhelming, bewildering problems, to try to navigate a system of care that would frustrate any of us. So I realize, too, that once we improve access, we need to be worried about the quality of care that people are getting, because we have evidence that even among those who are attempting to roll out evidence-based care, this is a study that Kimberly Hoagwood is one of the authors on, about 3% of states are really delivering evidence-based care. And of course, many of us have read, have served on. I was pleased to be on the most recent report of the then Institute of Medicine, trying to figure out how do we get evidence-based psychosocial interventions into place. And this has been the challenge that occupies me and excites me. As many of you know, the National Institutes of Health has decided that they'll put a little bit of money, not as much money as they're putting into other areas, but they've decided that we really need to better understand how to get a return on investment in our nation. How do we ensure that the treatments that are developed with federal dollars, the treatments that we all design and try to deliver, how do we ensure that they get taken up in real-world settings of care where people are? And so, as of now, 18 centers and institutes across the NIH have signed on to this common program announcement to support research on challenges of implementation. And this program announcement lists as the purpose of implementation science, and it's called D&I Research in Health, which stands for Dissemination and Implementation Research. My focus is going to be on implementation. The whole purpose is to figure out what strategies can overcome all of our barriers to delivering better care. How do we get proven, effective treatments adopted, integrated, and sustained in usual settings of care? And how do we begin to develop and implement evidence-based tools, policies, and guidelines? So we also understand that we all have limited absorptive capacity. And while we want to take on new interventions, interventions that are now shown to be less effective than alternatives, or interventions that are costly. There's a new JAMA report extolling the prevalence of waste in our healthcare system, a portion of which is due to our delivery of low value or unproven interventions. And so implementation research, the umbrella of this research, also includes challenging issues such as de-adoption and de-implementation. So under the umbrella of dissemination and implementation research, of course, implementation research is as I've described. How do we get the interventions that folks at your shop, my shop, are developing and testing, interventions that are proven efficacious? How do we get them to people? How do we get them out there where people can benefit from them? And it is a scientific study that basically brings in all the external validity and all the dirt and all the noise that in clinical research we like to carve out. In addition to implementation research, dissemination research focuses on how do we most effectively get information and evidence out. And we know that this is a particularly challenging time now. If any of you have colleagues who are doing vaccine research, you know the real pushback to the evidence. And so we need scientific study of how providers can, first of all, access in usable, feasible ways. We all can't do literature searches on every patient. So how do we get access to, and then how do we communicate evidence about what we are doing? So those are the NIH program announcements. I happen to love the definition that Carolyn Clancy, probably 10 years ago, when she was then director of ARC, said implementation science is really making the right thing to do the easy thing to do. Of course, we can argue about what is the right thing to do, but there are clear standards of evidence, of fit. So once we determine what we know we want to be doing, because all of us share a goal of delivering good care, then how do we make that easier instead of as hard as it is? Implementation science is really a subset of health services research. And this is David Chambers from NCI's slide, which he calls a big tent of terms and circles. So in health services research, we have these linkages between very important components of this science. In dissemination research, we really need to draw on health communication sciences. And in implementation research, we need to leverage what is being learned in quality improvement science and also have a bidirectional relationship. He has it going from quality improvement science to quality improvement, but I think a lot is being learned on the ground in quality improvement that then can channel back to our scientific efforts. So I like this now 10-year-old slide from the Institute of Medicine that talks about phases of clinical research, and often we're studying what to target. This is really where we're studying disease mechanisms, and then, of course, efficacy and effectiveness studies are what to deliver. Dissemination and implementation research then focuses on how do we do that? How do we get those rolled out? It's basically how do we change provider behavior? How do we change patient behavior around participating in treatment? And of course, we know that lots of stuff gets in the way. I have colleagues who are not implementation researchers, but who are clinical trial folks and even guideline developers who say, what's the big deal? Why do we need implementation science? Just do it. Well, that slogan may work for Nike, but I really haven't seen much in the way of when people tell us to do something, we do it. I don't like to take orders. You probably don't like to take orders. And certainly, I think the top-down, roll-it-out approach, I think we would not have the problems in quality of care if reading it and doing it were possible. We all wish it were, but instead, we have resource constraints. Things don't seem feasible. They don't seem appropriate because perhaps the evidence was developed in a group of participants who are much different than the patients and the consumers that we're treating. We have time constraints. We get rigid and we have routines. So all of these things get in the way. And the real challenge of implementation science is to figure out the leverage points and the most effective strategies to get beyond all of these barriers. So put another way, to contrast our evidence, our efficacy studies and effectiveness studies with implementation research, we're looking at what do we deliver evidence-based intervention and typically in terms of patient outcomes. And I'm the first to agree that this is the building block. Without a solid base of evidence-based interventions that have been developed through robust and rigorous efficacy and effectiveness trials, we're out of business in implementation science. We don't have anything to deliver. So we must continue to support and engage in effectiveness research. But in addition to this usual paradigm, implementation science adds another, if you will, intervention. It's the intervention of how, and those are called implementation strategies. I'll talk a little bit more about what those are. We also introduce additional outcomes. We want to ensure that those evidence-based interventions can be delivered feasibly with fidelity. They can have a large reach. They're acceptable. We can sustain them. And they have a reasonable cost, because if we don't achieve these are like the stumbling blocks. We'll never get to patient outcomes if the interventions are not actually delivered with fidelity. So within the context of health services, these factors are really the core of implementation science. Now, another factor that I want to highlight is the messiness, the complexity of implementation science. And there are many days that I want to say, this is way too messy, but we really can't deny the importance of these issues. So the complexity of implementation science is in part that we're looking at, we're looking at multi-level context. We're looking at policy context, and many of you are shaping policy for mental health policy for New York State. Many of you have very responsible positions shaping the delivery of services in mental health. And so your work is all about context. And so context is at multiple levels, and we need to learn to measure and analyze those and know what policies impact the adoption of evidence-based interventions and how do they do it. As I showed on the prior slide, we do have multiple types of outcomes. We have implementation outcomes and clinical outcomes, and those are interrelated. We also have the evidence-based intervention and the implementation strategy, which are very complex. And then we know that change is rarely linear and adaptation is typical. So these are the factors that make implementation science so complex and which challenge us all to develop methodologies so that we can have more robust study of the implementation process. So I just want to highlight why it's important to address the proximal outcomes that we're calling implementation outcomes. If we have effective interventions and we only look at clinical outcomes, we could actually have a situation where the intervention wasn't adopted. I've conducted studies of mental health clinics and tried to measure their delivery of evidence-based interventions. And we know that we have coding inaccuracies, we have self-report biases. We say, yes, I'm delivering this, but if we really probe and look, not all the ingredients, not to all the population of the clinic, so it's really not adopted fully enough to withstand a test of its relationship to effective clinical outcomes. Also, if it's implemented but the fidelity is poor, it's unlikely that we're going to see the clinical outcomes that we want. And we know that rarely are evidence-based interventions, especially those that are introduced through our grant funding, there's a great deal of difficulty sustaining those after we move away if we don't have sustained partner relationships. So fidelity, poor penetration, and lack of sustainment mean that we could test these, we could have an effective intervention, and if we don't see the positive outcomes, we might conclude that that intervention is not effective. But that would be a fallacy. Instead, we haven't given the intervention a proper test because we haven't measured these proximal interventions. So if we're going to really have rigorous studies out in the field, we have to address implementation outcomes to ensure that our conclusions are valid. Now, I've referenced the how-to of implementation strategies, and those are defined as the methods to enhance the adoption and implementation and sustainability of clinical programs. And I, as Lisa said, my career progressed from studies of treatment effectiveness, studies of access, to studies of quality. And our School of Social Work, where I am a faculty member, in the year 2000, there was one very interesting faculty meeting. I'm sure we've had other interesting faculty meetings, but this one really stands out because the curriculum committee, that even though I was not a member of the curriculum committee, and of course had been an advocate of evidence-based practice, but I walked into curriculum committee and the first agenda was that our school would adopt a formal commitment to deliver evidence-based social work practice and policy. A couple people said, well, I wouldn't have anything to teach because the evidence isn't that solid. And we said, that's really not what we mean. We're going to be transparent. Every intervention that we teach, every program that we teach, every policy that we're going to teach, we're going to be transparent about how solid the evidence is, and we're going to teach our students to question and to be able to critique the degree to which something is supported and that evidence is relevant to their area of practice. Well, because we have, of course, field education, and our students are not only in the classroom but also in agencies, we knew we needed to communicate and bring the field on board. And I was in the classroom when a student came back and said, I asked, why are we delivering this intervention? What is the evidence? And my field instructor said, don't ask so many questions. So we knew we had, this was way back, we knew we had work to do with the field to be able, what executive director wants a student doing an audit of the programs and saying, I think you should deliver this, and that's what we were teaching our students to do. So my research path got a bump, got a boost one day when an agency director, a very large child maltreatment and child mental health agency in St. Louis, the executive director came to me and said, okay, I get it. I'm really on board with what the school is doing in evidence-based practice. But he said, Enola Proctor, my organization delivers over 20 programs, and I believe only a handful of them are evidence-based. I want to decrease our delivery of those that don't seem to have much evidence, and I want to increase our delivery of those that have evidence. But he said, what are the evidence-based ways for me, an executive director, to pull this off? Now, you have to remember, this was the year 2000, and implementation science was only emerging as a field. And in 2004, I think David Chambers was hired by the NIMH, and we had met, and I called him up, and I said, Dr. Chambers, what are the evidence-based ways for agency leaders to bring effective practices into their agency? And he said, we've got a field to build. And that conversation really opened the door between David and me to begin to think about what knowledge do we need to develop. So I'm so indebted to that open, visionary executive director who really wanted to walk the walk, but challenged me as to how. And this is the question that propelled my work to identify, define, codify, and test implementation strategies, because really this is the question. So I've always written, this is kind of maybe a disclosure I shouldn't make, because you invited me probably thinking about some of the things you think I know. But my career has really been shaped by the things I don't know. And many of my papers were written because I had no idea how to answer the question. And this is a paper that a team of us wrote to try to answer that agency director's question. We turned to the literature on organizational change, on practice change, on getting interventions out there. And we tried to identify the words, the terms that were used to describe this concept we were going for, which is implementation strategies. And we came up with this refined compilation of implementation strategies, actually through 2 iterations. Our first paper was a literature review. In this one, we used some methods of concept mapping, where we queried experts, we queried implementation researchers, and we tried to refine a list or categories of implementation strategies. And they involve things that I think, we probably shouldn't be surprised about. People use financial strategies. We do pay for performance. We do prior authorization. So there are a lot of financial strategies. A lot of what we do is work with clinicians. We train them. We provide interactive assistance through coaching. We may have apps. There are many ways that we develop the capacity of providers to deliver evidence-based practice. We also develop stakeholder relationships, because we know that there's going to be pushback and there needs to be pull from stakeholders, people who care about services that are delivered. Often our efforts to implement involve tailoring and adapting the intervention itself to the population, to the providers, or to the setting. And we engage consumers, we change infrastructure. Task shifting is a perfect example of changing the infrastructure and educating stakeholders, and we engage consumers. We teach them to, I loved when, and many of you may remember this, there was a time when NAMI's website had a page that said, "Your loved one deserves evidence-based practice. Ask for it. Seek it out." And that, to me, was a beautiful moment in time when we were educating consumers that they had a right to effective treatment and they needed to ask for it. And then, of course, evaluative and iterative strategies, audit and feedback, plan, do, study, act. So there's a whole repertoire. We, in these two efforts, identified over 70 strategies. People are adding to them. So there's a whole repertoire. Not all of them, of course, would be used in any one effort. But in response to this agency director's question and my inability to answer, we set to work to try to identify implementation strategies. And they are distinct from evidence-based interventions. This is a slide that I developed by doing an NIH reporter search of funded implementation science, and just by reading the abstracts, tried to illustrate the distinction of the evidence-based practice from the implementation science. And you may recognize some of these folks. A lot of us know Marty Bruce, and for her depression treatment, she used implementation strategies of web-based training, supervision, consultation with audit and feedback. In addiction treatment, clinician training and payment policy, value-based purchasing. These are the kinds of things that are, these are the what, this is the what, and this is the how. And we need to ensure that we're developing a robust evidence base around the how. Now, implementation strategies are complicated. We know that behavior change and therapeutic interventions are complicated, and implementation strategies are no less complicated. So we use many of the same methods that we use to test interventions. We do comparative effectiveness research, cost effectiveness research. We're trying to figure out the relationship between strategies and empirically supported treatments. I'm sure we will have evidence at some point for a given evidence-based practice, which strategy costs the least, which strategy works the fastest. All of these are questions that we need to be asking. Which are most parsimonious, and which strategies are important for achieving which implementation outcomes. If we have people not accepting the evidence, doubting the evidence, or saying, no, I'd rather do it the way we've been doing it, there are certain strategies that will probably address that, much different than strategies that are going to address high cost or low feasibility of actually delivering it. And we're growing an evidence base about how, this is really practice-based research. There are folks, and I've been part of these studies, where the focus of implementation research is testing a particular strategy to see if it works. I happen to believe that every setting is already implementing. If people are walking through their door and they're getting services, they have implemented something. So it's rather naive of us to think that we're starting with a blank slate. So I have been intrigued with studies that are trying to capture what is working for people. So there are a couple of studies here that have looked at, in a couple of different ways, the strategies that people are using. In this article published, I think, earlier this year in Implementation Science, many evidence-based interventions have their own purveyor organizations that are set up to take the message out, to do the training, to do the coaching, perhaps do the certification. So we conducted a survey of key informants of a large number of purveyor organizations and found that the mean was 32 different strategies that they were using. Similarly, I'm part of a VA study group that has looked at a concerted rollout of hepatitis C treatment, and we use the same methodology to query the implementation drivers in those VA clinics. How did you do this? What did you use? And again, we found a very high number of strategies. Now, what do these findings mean? Actually, in the VA study, we found that the more strategies that were used, the more effective the site was in bumping up their delivery of hepatitis treatment. And we are also finding that people can describe what they're doing, but we're not really sure which are more effective than the others. I think that one of the major conclusions is that implementation is very complicated. I want to go back to that. And you may know the work of Joanne Kirchner, who is a major figure in implementation science, particularly in the VA. And we've done a lot of work together on implementation strategies. And in light of these findings that people are using 22, 24, 25 different strategies, I've often said, I wonder if we can really sustain this, is that we need to have a science that produces more parsimonious guidance. People, I can't go to, the CEO that talked to me and said, okay, I've got a list of 25 things you need to do. So I think that's a signal to our field that we need to test comparative effectiveness, and we need, it's also possible that our measurement, we're in a very early phase of measuring these constructs, and maybe certain words are actually meaning something else. So we've got a lot of work to do with the precision of our measurement. Joanne, who has her feet more directly in VA service delivery than I do, said, no, you're wrong. It is that complicated. If we're going to change systems of care, it takes a lot of strategies. So at present, I don't have the answer. I can't tell you whether the high number of strategies that people are saying they're having to use is an accurate indication of how complicated it is, or if because something isn't working, they're supplementing with something else. We need to stay tuned and keep doing the work on this. Now, I was trained in the era when, as a social worker, when our interventions were not very clearly specified. I remember the big debate between structured and unstructured treatment approaches. And we didn't hear much about treatment manuals or the specification of interventions. I think that was an era of moving from the art of psychotherapy to the science of delivering protocolized, well-specified intervention components. And I see echoes of that same challenge for implementation strategies. And therefore, part of our work to develop the lexicon, the language and the taxonomies of implementation strategies was very complicated by imprecision of language and by the absence of detail. Many studies would have a word or two saying, this is how we implemented it. So I guess I wasn't born in Missouri, but maybe I've been there long enough. We call ourselves the show me state. And I wanted to say, show me what this strategy looks like. What did you do? So with colleagues, we challenged the field to realize that implementation strategies carry the same demands as interventions for operational definitions, protocols and manuals, and fidelity. And we have written some papers calling for specification in reporting. And at minimum, we've said, if we're going to describe the implementation strategy of some training module, well, who does it? Who is the who? What do they do? What are they targeting? How much? For how long? And when? In what order? And why? What implementation outcomes is the strategy striving to overcome? And what is the theoretical or empirical justification? So we have a way to go. Colleagues recently published a paper where we reviewed the extent of operationalization or specification of implementation strategies. And we found that most people are naming it and they're telling who does it, and somewhat describing the action, but especially issues of dose, intensity, sequencing, and theoretical justification are often missing in our reports of implementation strategy. So that's one of my nudges right now to the field to help us get a language, get clarity out there about what implementation strategies are so that we can improve the rigor of our testing. So given that there are so many possible strategies, how do we decide which ones we should use? Well, obviously, just as our specification paper called for reporting the target, the implementation strategy should really be addressing particular barriers. And if providers are lacking knowledge of how to do it, it stands to reason that educational sessions would be important. We know that there's bias in reporting. We all want to do a good job, and therefore we tell ourselves and we tell others we are doing a good job. Sometimes the reality of services we're delivering, particularly around fidelity, don't match our own perceptions of what we're doing. And therefore, audit and feedback is a very important strategy in giving us some objective feedback. And there's quite a bit of evidence, even in a Cochrane review, that audit and feedback is an effective way of helping align perceptions. If people aren't motivated, sometimes we need to use incentives and sanctions. There's quite a bit of literature about opinion leaders and champions and the use of, like we are the worst messengers to go in and tell people what might improve care. It's much better to pick an enthusiastic person who is very similar. It's called homophilia, with the exception of the knowledge about the intervention. So picking a person who's respected and similar to the provider group, but has more expertise and more enthusiasm about the intervention, that's a really good way to address beliefs and attitudes. And then, of course, we know that our systems of care can be cumbersome and create additional barriers and sometimes preclude the delivery of evidence-based interventions, and that leads us to process or system redesign. Now, I've been alluding to several of the complications and the challenges of empirically testing implementation strategies. Certainly, language and terminology confusion. Practice facilitation is proving to be one of the most popular and probably effective approaches to implementation. But my definition of what's in practice facilitation may be very different from yours. So we need to really clarify and have better specification of who does what, when, and I rarely see manuals for implementation strategies. We have so far very few people are paying for implementation costs. There's very little in our payment structures to cover the costs of improving our systems of care. Our fee-for-service models mean that we're paid to deliver interventions. We're rarely paid to improve a system of care. We may get there with outcomes-based, value-based care, but Because there are no procedure codes for implementation strategies, we have a really hard time finding data by which we can capture the implementation strategies in use, and therefore we tend to rely on self-report. We have found, particularly in those 2 studies that I described, pretty good performance of structured interview items where we ask people, did you use this strategy? And we validated that by saying, well, what did that look like? How did you do that? And so, you know, I was skeptical that the language the field was using to describe strategies was really language that was familiar to implementers, be they administrators, providers, payers. But self-report is really one of the best things that we have to rely on. There are also really great observational methods, and I want to plug work of Sapana's colleagues, Allison Hamilton and Erin Finley, who are developing ethnographic approaches to study the implementation process, where we can observe and capture our measurement of strategies there. Archival records, as I said, there are no procedure codes, but people are using meeting notes. Staff meeting notes or reports to boards. The level of precision is going to vary, but you know, we do have documentation of policies going into effect. And so there is a great deal of promise in notes. And then, of course, we have a lot of different perspectives. In our very first test of the strategies compilation, I thought it would be good to conduct our first pilot by capturing the perspective of multiple stakeholders. So we had frontline providers, we had supervisors, we had treatment purveyors, and we said, which strategies did you use? And the team came back to me and said, this is a mess. We didn't get anything. People are, there's no agreement here. But as we began to probe, we saw there was agreement between the strategies reported across providers. There was agreement reported by strategies reported across administrators, which led me to believe that, it's everyone sees a different part of the implementation. Providers may not need to know what's going on behind the scenes at the policy level. It trickles down and people say, okay, we got to do this. But the strategies that were used to get a policy in place may not be may not be evident to them, nor perhaps should it be. Similarly, administrators, I've discovered that administrators do a lot to try to improve practice procedures, unit team meetings, but they don't give the rationale, and maybe they don't need to. So they have a logic to what they're doing, but it's not apparent to the frontline providers. And similarly, frontline providers are using resources that other layers of the organization may not be familiar with. So the fact that, we need to capture multiple perspectives, but we need to also realize that what one stakeholder is seeing and doing to pull off implementation may be not visible and therefore not known to other stakeholders. So this is another challenge in our ability to capture implementation strategies. So how do strategies work? The next frontier is not only learning what strategies work, but where, when, and how. What are the mechanisms of change? I have a junior colleague who's doing some fascinating thinking about de-adoption. What would make us ever stop what we're doing and adopt something new? I'm delivering the care that I am because I believe in it. It has worked. So what is it? Is it education? Is it motivation? Is it some kind of cognitive dissonance? What will help me as a professional to continue to grow and to continue to increase the repertoire of interventions that I'm skilled to deliver? So studying how these strategies work and how we can improve their effectiveness is really a frontier. So I want to close with a couple of additional points. One is, what are some of the priority questions in implementation science? And then a little bit about some resources in the field. So one of the priority questions is, how early in intervention development do we need to start thinking about implementation? Is implementation an afterthought? Or how early can we begin to think about this? Well, clearly, we need to wrestle with these issues, and there are some design innovations that are helping us do that. Jeff Curran and colleagues have written the classic paper now on hybrid effectiveness implementation designs, and they have positioned hybrid designs right here between actual effectiveness or efficacy studies and implementation research questions. And they've identified 3 types of hybrid designs. In hybrid 1, which is really the earliest, we're really testing an intervention or a prevention program, and we're gathering data about the implementation. And I hope we're reporting those data. I once was working on an implementation project and finding refusal rates among patients higher than I wished. And I thought, what is it? We're taking it to them, it's free. And I began to look under the hood at the effectiveness studies, and their refusal rates were higher than ours. But rarely do we see how acceptable, even in the lab or in initial tests, how much people want to participate in these interventions. So if we could gather and report everything about how much time does this intervention take? Who is the provider delivering it? How much does it cost? If we could begin to capture that, that's going to inform our subsequent implementation research, and many of us think will shorten the long delay in moving something to the real world. Hybrid 2, you kind of equally balance effectiveness questions and implementation questions. And in hybrid 3, you're really testing an implementation strategy, yet continuing to monitor clinical outcomes so that you know that the effectiveness holds or that you don't see an effectiveness drop-off. So this is a really important innovation, and it's helped us know much more about the implementability of interventions at the time they're being developed and tested. Another cutting edge is that really involves how quickly we move things out is implementing genomics in practice. And this is an area where I believe we're at huge risk of exacerbating disparities. And I do believe that disparities is inherently an implementation problem. It signals huge variability in implementation. And our medical knowledge based on genomics is accelerating much more rapidly than is its acceptability and its readiness to be moved into practice. And the NIH has, by establishing several coordinating centers, have begun to say we need to be thinking about how we're going to implement genomic medicine. And I think one of the reasons is to slow down or reduce the disparities that are likely ahead. So how do we start? How do we move forward? Clearly, hybrid designs and designing for dissemination and early implementation, thinking about who would deliver this, how can we make interventions better suited for uptake. And that's a real challenge for our intervention development community. I want to encourage those of you who are intrigued with implementation science to join the first conference was, I think in 2004, there were 250 people. Now there are upwards of 2,000 at the annual conference on the science of dissemination and implementation research in health. One of the things that I find most exciting about this is that it reflects the cross-institute nature of the program announcement itself. I remember being stopped in my tracks when I attended a session. There were 3 papers, and I wanted to hear one. And one of the other papers was by an oral health researcher. And I thought, so I have to sit through this to hear the other paper. We've all been there, right? But he was addressing the very same implementation problem that I was in mental health. So one of the really exciting features of this conference is it is NIH in a microcosm. There are people whose research is supported by all the institutes, but they're focused on similar questions of how do we improve care, how do we accelerate implementation of newly proven care. For those of you in mental health, I want to give a shout out to the Implementation Research Institute. Harold has been an expert faculty member. Sapana is an early alum. Lisa also has been an expert faculty member, maybe some of the others who I'm not seeing or remembering. But we're now training our 8th cohort, and we will be submitting, if I have to be up here, you have to be up here too. We're planning a submission of a renewal, so we're recruiting on a very limited basis this year, but Mark, keep hopeful with me and send us your students. So I want to thank you for your attention to my thoughts about implementation science, its role in helping boost the impact of the terrific intervention, development, and testing work and service system work that you're doing and all of us as mental health services researchers are doing. And thank you once again for the wonderful award. It's a thrill to be here.
Wow. I've never actually taken pictures of slides before. So we have time for questions.
Harold.
Hi, Enola. Congratulations on the award.
Thank you.
And terrific talk. So I have 2 related questions. One is, could you say a bit more about the border between implementation and dissemination? And in particular, the role of policy and regulation in that?
Okay. So the question is the relationship between implementation and policy and regulation?
Yeah, but also the border between implementation and dissemination.
Okay, the
Yeah, 'cause
border
everybody's
between
always talking
implement.
about DNI, but
Maybe somebody here will take me up on it. For several years, I've said we need a good conceptual paper that really outlines the paths between dissemination and implementation, and I see it as potentially bidirectional. I don't think we can implement something until until the evidence has been disseminated. But how do we there's very little funded dissemination research. This is a wide open field.
It might be good just to actually repeat.
Okay,
I know you had a slide on it,
yeah.
but,
The definition of dissemination research is research that looks at how research evidence spreads. How does it reach its intended targets? And I lived through a number of pains. One of my first struggles with the notion of evidence-based practice was I thought the literature inappropriately placed the burden on the individual provider's back. That said, if the provider just reads enough or gets enough training, they can go out and deliver evidence-based intervention. Well, who has time to read research reviews on every patient we see? So one of my early papers was about how do we make the evidence accessible? How do we make it easily accessible? And that was even before I was really into the, I don't think I used the term dissemination, but I was really struggling with that out of the evidence-based practice movement in social work. So how do we get evidence? Well, we do read. We go to trainings. There used to be websites. There used to be an NREP. with SAMHSA, which now is no longer being maintained. And I'm not saying some of these are the most effective, but I think we have to do some research about this question of how are your discoveries going to reach their intended users? And does dissemination happen
Twitter,
first?
obviously, is the answer.
What is?
Twitter.
Twitter, yes, yes. Boy, try keeping up with the young folks on, and I tweet. I have 3 accounts, but I even sustained a Twitter related thumb injury once, which shows that I was really into it. It was at IRI. How dissemination research is under resourced. We don't have enough people conducting it. Many people have said it's the opposite. We shouldn't disseminate until we have shown that something can be not only effective, but implemented. Why would we disseminate information about interventions that have not been shown to be implementable? So I challenge one of you or anybody to write a paper to help us sort out what is the relationship between dissemination and implementation. I developed a course. I figured this was my final exam as a professor. I developed a course called Implementation Practice for our master's and public health programs, where I wanted to pass on the skills of how to implement to people who would be working in clinics and agencies. And I had imposter syndrome for a long time because I didn't want to walk into the classroom and teach any strategy that I couldn't point to the evidence. And I was spending weekends searching for evidence reviews. And my husband said, "Why are you doing this at your stage in your career? You're making up a course and you're spending 7 days a week trying to get enough evidence to walk into the classroom." And I said, "Because I need to know what strategies work for me to teach it to these students." And one of the resources that I found had a wonderful way of organizing it, and I realized how critical communication is to good implementation. Champions, advocates need to be able to clearly describe the benefits. Supervisors and administrators need to bring teams on board. We need to be able to effectively communicate evidence to legislators, to policymakers. We need to have not only evidence, but how do we persuasively communicate the evidence? So I think in some ways we're stopped in our tracks in implementation, many implementation strategies, until we have learned from health communication and dissemination research how to communicate this. So that's a long, wandering answer to your question about, I don't know the relationship. I think we need to figure it out, and I see many threads in both directions. With respect to policy and funding, many of the strategies do involve policy change, structuring our payments different, and I would not begin to tell you to try to describe that world to you because many of you are very immersed in that. Jürgen Unutzer once said to me, implementation just is a simple matter of paying. Pay for it, pay people to do it, and it will happen. How we get there, I don't know. I mean, I agree that there's a lot of power in payment. I was talking to Sapana and encouraging her to contribute to implementation science from all of your experiences with the New York State office and your work with legislators. Jonathan Pertl at Drexel is an alum of our Implementation Research Institute, and he's doing research on legislators and legislative staff knowledge about mental disorder. Many of them think that mental disorder means living on the street or gun violence. And there's a lot of work to be done there.
We actually have a psych services podcast in which we interview Jonathan Pirtle, so
Yeah.
check out the podcast.
So, Harold, you've raised two important areas where the field really needs to be developed. So my comments are just a shout out to that.
Hi, Enola. Thank you for a wonderful talk. I want to ask if I could ask you to push a little bit on the question or say more about the question of how early should implementation type research be conducted with efficacy, very early efficacy like intervention development, because it's something that we struggle with a lot, particularly in a field where we're trying to overcome disparities.
Yeah.
And so trying to generate new interventions that are feasible, but at the same time effective. So and this is something that one could extrapolate to all kinds of new interventions.
right.
To what extent should we be developing more interventions that most people don't have access to?
Yeah. Yeah.
So at what point do we include, even at the earliest stages, some idea about how feasible doing this will be?
Yeah. Really important question. And again, one that I think some progress is being made. There are some areas of literature. Aaron Lyon's work on designing for dissemination, or I'm sorry, user-centered designs, where, have any of you heard him talk? He brings a lot of, like his talks are populated with slides of things that like we can't, that are unwieldy to use, and I mean real things in the real world. Doors where the handle is in the wrong place, or and our lives are filled with unusable things in the world. And so his recommendation is that we have the user sitting at the table while we are developing. And I think PCORI, we have a project at Washington University on, it's a multi-site study, and Columbia is a site, but Eric Lenz is the PI. Anybody on that project? So PCORI funding was very effective at requiring people to get users at the table while the intervention and its properties are being discussed and developed. So asking questions about, is this a priority in your life? My research on depression with older adults, I found that providers often thought, well, it doesn't need to be treated, they're just old. Or older adults said, of course I cry. I'm lonely, I have functional impairment. They didn't perceive that depression was even something to be treated. And so building interventions, shaping them with their language or in their world. Again, my colleague Eric Lenz had a fall rehab program. And he said most rehab teaches people, okay, now we're going to work on flexing your knee. And he turned it around and said, what do you want to be able to do? And they said, I want to be able to pick up the newspaper off my front porch. I can't do that. And I'd like to be able to make it to the door to let the dog out. So the rehab was completely repackaged or shaped around, okay, we're going to be working for the next 2 weeks on picking up your newspaper. So labeling the intervention and its purpose and the steps of participating in it around functional activities of daily living that people want to do is one example of designing the intervention to maximize uptake. I think it's a very cloudy relationship between do we test an intervention first to see if it's effective or efficacious even without that input, because with that input it might be more efficacious in the lab. So when we do this, I think is yet to be determined, but the overall message is we need to bake in usability as we're developing it. Who would deliver it? How many sessions? I work with an obesity researcher who had an 18-session protocol for childhood obesity. And I said, that is not going to fly. And she said, yeah, but we have to have these components. Well, then it was whittled to 14, and then it was whittled, she got it down to 8, but she was convinced that it would lose its effectiveness. And we were convinced it would lose its implementability at 18 sessions. So starting with those kinds of considerations, counting the number of provider hours required so that up front people know what it's going to take. Yeah, I see another hand.
That was a lovely presentation, and I'm a real fan of services research, and I think Lisa's program here has made an enormous contribution, actually, to early intervention with first-break psychosis. But I have put a question another way. This is something I'm sure you've thought of, but I certainly haven't figured out, and I've tried for a long time to figure out strategies. How would you, if you thought that patient-centeredness as a overarching paradigm for any intervention, and this is the opposite end from Harold's question. This is where the clinician meets the patient. If you've thought of patient-centeredness as crucial to the paradigm, just the example you gave of in the rehab, what the person really wanted, have you thought of ways to strategize and implement that to increase that issue? That's been a struggle with the Office of Mental Health for decades now, since we've been aware of it. But how do you get people thinking that every bit of care is individualized and centered around what the person really wants?
So the question is, what are the limits of tailoring to an individual? Sure. Yeah. Well, we're always, and I think another challenge that I think affects, that implementation science wrestles with, is what is generalizability and what is, as Tip O'Neill says, all politics / all implementation is local. And quality improvement emphasizes solutions for the here and now, if you will, not the patient, but the system level. And what we've lost is the generalizability. So for me, the way out of this conundrum is to be able to identify in generalizable terms how we get to patient-centeredness. For instance, it might be querying people about their priorities or their preferences. Which would you prefer? And while the specific solution may be specific to a patient, the approach is something we can teach clinicians to do across the board. So, some rehab patients might say, getting to and it may be the same exercise to let the dog out and to pick up the newspaper off the front porch. You probably have to bend down more to pick up the newspaper unless you have a claw. But, you could tailor the motivation for the patient individually and yet follow the same principles that it's simply communication and framing. And unless there's a scientific reason to do things in a different order, maybe you have to walk to the door before you can bend down. I'm not a rehab specialist, but then you couch, okay, we're gonna walk to the door first, and then we'll work on bending down later. So I think it's generalizable approaches, but specific application.
Hi, Enola. Thank you. Great talk. Could you say a couple more words about, I'm sorry, Milton, de-implementation? I think you're at the state policy level, we're struggling with that. We've got these wonderful examples, for example, the first episode, Psychosis Raise, on track of these initiatives that are well-tested, demonstrated effectiveness, and then they get rolled out statewide. We scale them up with a fantastic implementation strategy because we have Lisa Dixon doing it, right? But those are a minority of our projects. Most of our projects in the state are funded, many of them are funded serendipitously, right? There's episodes of violence and gun violence that leads to the governors and mayors saying, get rid of it, and all of a sudden there's a bunch of money, and then you implement
yeah.
mobile crisis or crisis, CTI teams or what have you, and you got to do it fast.
Right,
So we have all these programs and hundreds of millions of dollars that are paid, and we look at them and we say, well, they're not working. There's not fidelity to the model. They weren't implemented well, maybe because they didn't have enough time. When do we cut bait? And the message coming to us now is you got to start cutting out programs that aren't meeting their goals and using our money in better ways. So you caught my ear when you started talking about de-implementation. And what advice do you have for us in these kind of situations?
Yeah. Really underdeveloped, but very real-world issue, too. Some of us who've dabbled in this have looked at the Choosing Wisely campaign, which is not really based on evidence, but there are a lot of messages. I mean, the strategies aren't. But I remember going to my primary care. I'd had a cough for like 6 weeks. I was functioning, but I was sick of it. And I went into her office wanting an antibiotic. It's like, enough of this, it's a virus, rest. Who has time for that? And I walk in, I register, and I turn around to sit down, and I see posters everywhere about antibiotics are not effective for, and it listed everything and I thought, I am not going to get an antibiotic. So some of the de-implementation has to do with communication, disseminating the evidence. I think we have a more basic and pervasive problem, though, and that is, and I struggle with this because as a social work faculty member, we train people to practice, and I'm teaching people the best of what I know. But I also have to tell them that what I'm teaching them today is not what is going to be the best approach once we have new research. And, I struggle, that kind of erodes confidence, right? And it's hard being a provider. We're dealing with some of the most challenging problems where people's emotional and physical well-being is at stake, and we want to do the best. So we want to believe that we're delivering the very best service. How do we do that? What kind of professional socialization do we try to have for providers to say, that's going to change? And throughout your life, you're going to have to be willing to cut bait and get something new. So socialization, messaging, payment, and I worry so much because that really leads to being very cynical. People say, well, now we have to deliver the flavor of the month. From coming on high, we have to stop that and start doing this. Part of that, I think, is that people don't know the reason, but also as individual providers and as providing organizations, we're not that nimble. So we've got a lot of work to do to figure out how we pull this off. I think it's a given. None of us are delivering interventions that were effective 30 years ago or thought to be effective. So it's a reality.
If I could ask a follow-up to that, I think it sounds like implicit in what you're saying as you move to this notion of we have to keep learning is that part of stopping something is starting something else.
Yeah.
So that it would seem like very important in this system to it's not just about stopping. It's then now what can we do? How can we build on what we've learned? But that you have to offer something when you're stopping. I mean, would you agree with that?
Yeah, and I think, if we can get to more evolutionary approaches, where we don't, I've seen some social service organizations like chase the mission. Their identity is completely different over a 5-year period of time because they chase the money. And I often think, what happened to the needs you were meeting before? So, that's a kind of an organizational definition of who we are, who do we serve. because there should be ways of bringing in new technologies while continuing to meet the needs of the population or the mission that's at our core.
Well, that is fantastic. I think we're about out of time, or we have one more? All right, did you? Okay, all right, go ahead. Sorry, it's great that everybody wants to ask questions.
And I'm sorry
wish
if
we
I've
had-
taken too long in my responses to.
I just wanted to congratulate you on your award, Enola, and it's so great to have you here with us. I wanted just to underscore, because I've been hearing this throughout all of the questions, and something that you've highlighted, which is communication and translation from the research that goes on in implementation to the practitioners out there. I think it's such an important piece of what we need to develop more as a skill for the next generation of D&I scientists, because we can do the research, but then when we're in an organization, like, for example, the Center for Practice Innovations, we're tasked with translating some of that information for program supervisors and managers so that it's palatable, so that they can actually do something with it.
Yeah, yeah.
And so I just wanted to put in a plug for that, as you continue to support the next generation as well. And thank you.